So thank you everyone for coming out bright and early today. If you don't mind coming down some stairs, we're a small group at this point, and it would be nice to have everyone a little closer to the front. So this session is on 3 different ways of estimating the cost of universal health coverage. Karin Stenberg, David Watkins, and I and our research groups worked on this independently, and still we came up with estimates of the cost of universal health coverage that are quite similar. So I thought it would be interesting to present to you the methods that we use for our 3 different estimates. And then we've invited 3 discussants to talk about their experiences with universal health coverage in their countries. Then we'll have a time at the end where we would like to invite attendees who are doing universal health coverage to talk about the approaches that you're using to estimate the cost and to estimate budgets. So we'll start with Karin.
Is the sound okay? Okay. So good morning, everyone. Thanks a lot to those of you who made it here despite the early hour and the gala reception, which took place last night. It's fabulous to have you all here, and we hope more people will come in as we continue. So thanks, Marcia. I'll be talking about WHO's approach to modeling investments needs for UHC. I'll basically be talking about a paper we published 2 years ago where we looked at what are the investments required across 67 countries over a period of 15 years if we want to attain health SDG targets. So the background to this is that WHO, many of you might know that over time, WHO produces global resource needs around the required investments to strengthen health systems and to reach global health targets. So we have specific strategies and global asks for specific diseases such as malaria or TB, but we also work on sector-wide assessments on resource needs. So what we found a couple of years ago is that as we were moving from the MDG era to the SDG era, countries and academics were still quoting estimates that we published in 2009, which were published as part of the high-level task force on innovative financing. And those estimates concluded that on average, low-income countries would need to spend around $60 per capita on average if we wanted to attain the MDG targets in low-income countries. But in 2016, we found that a lot of people were still citing these numbers, using these numbers. So for example, the Commission on Macroeconomics, the Commission on Investment in Health was also using these estimates from 2009 to look at the cost of investing in health systems. And we concluded that we needed to update those so that countries and partners would have more comprehensive estimates that really reflect the SDG agenda and universal health coverage rather than the MDG agenda. So what we decided to do then was to do a global cost analysis that really looked at the SDG agenda with UHC in the center and to project the likely attainable health outcomes towards the SDG targets as well. So not just the cost, but also how far low and middle income countries would progress towards the SDGs. And we also wanted to look at impact measures that really reflect the full SDG and UHC agenda, like life expectancy and healthy life expectancy. So we had these, like in 2009, the $60 per capita. We also had in 2014 a report that said that countries, they had just inflated the $60 and to $86 per capita, or 5% of GDP. So the question is it enough to have these kind of benchmarks to reflect what we need to invest for UHC? And we felt that no, the MDG agenda was more limited, and now we need to move towards a more comprehensive estimates. So this is the paper. I'll very brief in this presentation, but basically if you want to read more, it's a paper published in Lancet Global Health in 2017. So the scope for our analysis, we looked at 67 low and middle income countries, and they represent 95% of the total population in these countries. So it's really representative for a global price tag. We're just looking at the global resource needs for the SDGs. And the essence of our analysis was we expanded the coverage of about 200 health interventions. I think it's 186 health interventions. But we also modeled the kind of expansion in health systems that would be needed to provide these services. So we also modeled across the 6 health system building blocks framework what investments are needed in every country towards benchmarks for UHC. So what kind of health worker ratios are needed, what kind of health information systems are needed, what kind of governance structures need to be in place, and we estimated the cost so that countries could reach those benchmarks. And we also looked at emergency preparedness and response. And then how much to invest? We basically varied the coverage targets that countries should reach by 2030 according to the country-specific context, at the same time using the globally agreed targets or benchmarks as the final goalpost. So the model approach is we're using peer-reviewed and published tools. So the modeling framework is basically built around the One Health tool, which is a tool that has been extensively used both at the global and the country level. So we modeled the resource needs by country and by year, going towards 2030. And we based it really on data for each country on what's their current health system, what's their current epidemiology, and what's their current coverage. So we have 67 country models. And we used an ingredients approach. So we defined the benchmarks, we define the ingredients or the quantities that are needed to reach those benchmarks, and we attach a price to each ingredient. And the prices are country-specific. So within WHO, we have a lot of databases with country-specific price estimates around things like salaries, workshop costs, per diems, fuel, etc. And then our model assumes that we have an efficient system and that we're going to reach the standard of performance that we aspire to as a UHC benchmark. So for example, for health workforce, there are benchmarks that we took in terms of the population density required in terms of the health workers needed, and also the kind of mix of health workers that would be needed to deliver the services. And then we compared with current existing health workers in those countries from health workforce accounts. We calculated the gap, and then we modeled what it would cost to reach the normative target for health workforce density. So the interventions, the targets and activities were as much as possible based on pre-existing strategies and global price tags. So we aligned with the UNAIDS price tags, the work done by globally on TB, malaria, and other specific programs. And we had an explicit ambition to model every country reaching these targets. We used integrated models so that we can take into account synergies. So these are, within the One Health tool, we have integrated impact models. So for example, if you scale up family planning, you have fewer births, so there will actually be fewer cases of newborn illness and childhood illness for you to treat and manage in the future, even if you don't expand the coverage of those interventions. So we have modeled all of these interactions. And then we had a country validation meeting. So we had 16 countries come to a country validation meeting, the 16 largest countries, and we discussed the assumptions and we discussed the data we used for their countries, and they validated the model. So we think we have a pretty good validation process in place where we can say that countries agree that the approach and the data make sense to them. So this is just to show you that how detailed we go in our modeling. So this is just one intervention, and we use defaults from the One Health tool based on treatment guidelines from WHO, where you can see for each input, we really specify the quantity for each patient that needs that intervention along with the price. So this is all available in this publicly available tool. So what's the unique contribution of this study? I think I just listed 4 things here. So the first thing would be that we are really taking a health system focus. So in addition to modeling a package of interventions required for UHC, We are also very much considering what are the health system investments, because I think the evidence has shown us for the past 10 to 15 years, even while investments in health are growing, investments in health systems have remained more or less at the same level, and we are not seeing the kind of investments that would be needed to fully expand coverage. So in our model, we very much show the need to invest in health systems that's driving the cost across all 67 low and middle income countries. The second unique contribution is that we're actually using tools that are readily available and applicable for any country to pick up and use at their country level. The One Health tool was originally developed for country level use. It's not developed for global use. So this is a tool that has been available since 2012, and countries can pick it up and they can do their own analysis. The third unique contribution is we are projecting health impact using integrated models. So as I mentioned, when we scale up some of the promotive or preventive interventions, there's feedback loops within our models so that we can assess the final health outcomes from an integrated package. And finally, within our model, we also consider a varying country context and a variation in country readiness to scale up. So what this means is that, as I show you in the next slide, we divided countries into 5 groups: conflict, vulnerable, and then 3 types of health system strength, countries with differing health system strength. And we basically said that there's no one-size-fits-all, but countries need to scale to the pace for which they have capacity. So the scale-up curves are also set for each intervention and for each country individually. So we're not using uniform scale-up curves, but we really model the scale-up curves according to the capacity of each country. So some of the limitations is we don't include everything required for UHC. Our models exclude certain very important interventions like hepatitis, rehabilitation, etc. But we are working on addressing those now, and a hepatitis price tag is about to be published. So we are working on addressing the gaps. And in general, it's a conservative estimates of resources. We think our estimates, we actually need more than what we estimate. So very brief in results. For our model, we say we need an additional $76 in low-income countries, an additional $8 in lower middle-income countries, and an additional $51 in upper middle-income countries. These are average numbers, so countries will need different amounts. But we can see the main drivers are really infrastructure and health workforce, and we see that across all countries. The main platform is first-level clinical services, so we're seeing where we need to invest. So it's really a key message for primary health care. And finally, just wanted to show you that we're also modeling life expectancy gains, and you can see the differences in what's driving the life expectancy gains across different types of countries. So in many countries, the RMSH, reproductive maternal child health, is still an unfinished agenda, but in the higher income, middle income countries on the far right, we see NCDs would be the main area where we can gain life expectancy. So thank you very much.
We have a few minutes for questions about Karin's talk.
If we have a few minutes, I'll just put this slide back just to say that we think in the future X will be higher.
Yeah, go ahead. Yep.
Thanks, Karin. I was just wondering on the validation process, it was pretty interesting. What kind of stakeholders did you include in the validation process?
Thanks, Andrew. So for the country validation process, so we asked the 16 largest countries in terms of population to nominate somebody from the Ministry of Health who knows about the health statistics and the general health situation of the country, ideally a planner or health information person, ideally from the Department of Planning, or it could be from a related institution like Public Health Institute. So each country nominated who they think should attend our meeting. And we also had global modeling experts at our meeting, so from the World Bank, other UN agencies, academics, who also guided us on the model in terms of the components that should be included and the data itself that we're using.
Other questions?
Thank you. You went very quickly through one of the slides on the investment, the best level for investment. I think, was it, no, sorry, afterwards you just went past it. And I just wanted to know the next one, the country's response to that information, the results. The next slide. Yes. Could you describe the country's responses to this and to this information in terms of investing in the first level clinical services when usually we see health budgets focused at hospital level? So what was some of the feedback from the countries on those?
Yes, thank you. So I think the feedback was in general affirmative. Countries recognize that a lot can be done in terms of progressing towards UHC and SDGs by investing in what we could call the primary healthcare platforms. So a lot can be done in terms of providing policy and population-wide interventions and outreach services that is not very costly. So we can actually achieve a lot by population interventions or behavior change interventions without having to spend that much resources in terms of the impact. But the majority of preventive and curative care in our model was modeled to be delivered through first-level clinical services. I think in general, our country respondents, felt comfortable with this type of results. It also gives them some leverage to argue within their countries that they need to strengthen primary healthcare platforms. So that being said, this is conditional on the types of interventions we included in our model. So had we included more tertiary level services, that part of the pie might have been bigger. So it's also conditional on the kind of interventions, the kind of models we had available at the time of the study.
We have time for one more question.
My name is Grumay. I'm from Ethiopia, Harvard project. I'm just wondering, looking at this, the statements in the quotation saying that it really depends on countries. Is this an implication that the WHO guideline, like $80, $60 for low-income countries to provide basic services, is there a shift? Does this mean that it really depends on context or countries? Because I hear in every conference and workshops that countries are kind of referring to these figures as where they are in terms of understanding whether they are spending enough per person or per capita to meet WHO guideline.
Thank you. Yeah, so just to be very clear, thank you for that. It's true that the numbers that have been published, like the $60 per capita or $86 per capita, remain widely quoted. And we think there are some limitations with that because every country effectively will need to spend a different amount depending on their health system, their epidemiological context, and also the kind of price level. And we also know that even if we might aspire to provide the full package, there will be budget constraints. So in this most recent analysis, we don't produce just one number. We produce a range of numbers for different settings. And we also very strongly emphasize that each country will need to carry out their own analysis to really assess the required spending to reach the SDG targets. So basically, there's no simple answer. There's no simple number to say that everybody should spend a certain amount, because in the end, it all depends on the system, the efficiency within the system, and the resources available.
Thank you, Karin.
Thank you.
Very good. So next, clap.
Okay.
Next, David Watkins will be presenting on estimates from the DCPC project.
Is this working? Oh, perfect. Good morning. Thanks for inviting me to present Marcia. So each of these three presentations is different perspectives on the cost of universal health coverage. So I thought I would spend just a minute talking about defining UHC and defining what is being costed, because I think that's part of why these studies are different and why it's interesting that they're also somewhat similar in terms of what you get in terms of numbers. Disease Control Priorities, third edition, for those who don't know, was a 7-year international effort, over 500 collaborators from all over the world, to try to define what are health priorities for particularly low and lower middle income countries that face significant resource constraints. There's 9 volumes published over 3 years and produced, amongst other outputs, a series of what are called essential packages of health interventions. Essential packages of health interventions. These packages, there's 21 of them, and they're oriented around a certain disease or professional communities such as cancer, cardiovascular disease, surgery, reproductive health. And they really synthesize lists of interventions that have evidence for cost effectiveness, relevance, feasibility in low and middle income country settings. So in the final stages of DCP3, when we began to synthesize all this work together and find out what does this mean for the SDG and UHC agenda, we created a series of 2 model UHC benefits packages that aggregate and synthesize and harmonize all these interventions across the different professional communities to try to come up with one coherent vision for UHC. So we define UHC not in the whole sort of like idea of UHC, but a focused definition of UHC called essential UHC, which is a health benefits package that's guaranteed, prepaid to all the population. That essential UHC or EUHC package contained at the end of the day 218 health interventions from across DCP3. And we further defined a subset of those interventions called the highest priority UHC package, or HPP, which was 112 interventions. And we got to this highest priority package really thinking about the resource constraints and needs of low-income countries. And so the HPP was defined as a subset based on criteria of very good value for money, financial protection, equity considerations, and other sorts of things that might be especially relevant for defining a benefits package in a low-income country setting. And so you can visualize how we thought about our UHC packages here. If you look at this sort of pie and this green circle is sort of UHC is defined by France or Sweden or something, everything can be done for everybody. Then essential UHC is this sort of purple sphere within it, which is a package of interventions that's offered to countries with certain resource constraints, and then the highest priority package is a further subset of that. And you can divide it roughly into the things, the sort of traditional unfinished agenda, infections, maternal and child health conditions, nutritional disorders, things like that, as well as the emerging non-communicable disease and injury agenda. So how do we frame our cost analysis? Well, we didn't start out trying to produce a resource projection model. We started out producing packages of recommended interventions. So the costing work we did was really designed around understanding how these interventions fit within a system. The global health costing literature to date, as many of you know, like the wide variety of methods used, a wide range of data sources. There are very few large scales, particularly before 2017, before One Health tool came along, very few large scale costing studies related to health benefits packages. And so this is really meant to be a sort of, you might call a highly informative Bayesian prior for, local costs. We wanted to produce for typical low and lower middle income country settings, what the magnitude of cost of all these interventions together. We didn't try to define a scale-up pattern, we just looked at what would happen if you had higher levels of coverage of these interventions for this package of services today. And these are long-run average costs, steady state costs. The animations aren't working today, so this is all here in one. But this is a very simple sort of model where we sort of, again, an ingredient sort of approach where you take population and need, which is based on demographic and epidemiologic data from UNPD, global burden of disease, and other sources. We have baseline coverage from WHO indicators where they're available, from the literature where they're available, from expert opinion where there are no data. We set an 80% coverage target for all of our interventions, and this is something we debated quite a while, like what's realistic. So to sort of compare apples and apples, we tried to say, well, what if we get to 80% coverage of everything, including everything from vaccines to hypertension treatment? By 2030, what would that look like? And so, again, that's for both of the sort of smaller package, highest priority package, and for the larger essential UHC package. The unit cost data that we used were mostly from the literature, and we adjusted and inflated all those estimates to in this case, 2016 US dollars, and adjusted them to sort of average lower middle income country settings based on the composition of the unit cost by traded versus local goods and those sorts of things. We have health system strengthening costs, which are a function of the sort of service delivery costs themselves. So this includes the health system costs, labor, capital, supply chains, things like that for delivery of these interventions. But in contrast to what Karin was saying, we're not looking at getting to certain targets for health system capacity, just the required health system investments to support these particular interventions. So what are the unique contributions of this study? I think there's probably three things that we can learn from our costing exercise that really frame the debate around especially expanding UHC in low-income country settings over time and addressing the sort of epidemiologic transition. The first is that most of the incremental investments in health systems would be for, whoops, that's interesting, that's not working. Most of the incremental investments would be for urgent interventions and chronic interventions, but not sort of routine vertical programs. And they would be at first level, as Karin was saying, first level clinical services, health centers, and first level hospitals, and I'll show you that here. This is, shows the shares of cost across countries according to these 5 delivery platforms. And so health center platforms are here. First level hospital platform is here. And so these are sort of chronic interventions like antiretroviral drug treatment, diabetes care, things like that. These are urgent interventions like surgery for trauma and that sort of thing. And so you can see that the vast majority of costs are for health centers that are doing kind of outpatient chronic care, and for first level hospitals that are sort of doing emergency care in particular, but there's obviously some overlap. And most of the current investments are kind of centered around here, right? I mean, a lot of community-based care, a lot of, in the health center care that's being done, a lot of it's for urgent interventions. So we're really looking at investing in interventions that really move health systems more towards things like non-communicable diseases and injuries over time. And I'm really sorry if the animation's not working here, as the health benefits package portfolio expands from, for instance, the highest priority package to the essential universal health coverage larger package, you would see more relative investment in, for instance, purchase of reduction in non-communicable disease mortality versus child mortality. And as unit cost of interventions go up, as you expand, the relative importance of financial protection increases relative to the purchase of mortality reduction. So systems, as they expand, move more away from reducing mortality levels to move to protecting populations against high-cost interventions and disabling interventions. So I'll show you kind of what that looks like here. We classified all of our interventions, all of our 218 interventions, into one of 5 categories. One, interventions that reduce mortality amongst under 5s. Interventions that reduce mortality amongst over 5s from sort of the group 1 causes, infections, nutritional disorders, maternal disorders. Interventions that reduce NCD and injury mortality. Interventions that reduce disability but not mortality. And interventions that improve non-health outcomes, such as family planning services, palliative care, and those sorts of things. They don't have DALIs attached to them. And you can see that for low-income countries and for lower middle-income countries, as you expand from a sort of a more focused package to a more ambitious package, where the sort of resource constraints, cost-effectiveness constraints are less, then you have more relative investment, both in the absolute numbers and in the share of, in particular, non-communicable disease mortality reduction. So a lot of the costs are going towards cardiovascular disease and cancer treatment in both low and lower middle income countries. You also do have some increase in cost of infection control for adults as well, and some increase in the cost of reducing disability, particularly rehabilitation services and other sorts of things that become particularly important as mortality patterns wane and non-fatal outcomes become more important in countries. So we think that this is a really useful way of thinking about the relative balance of the types of objectives that a health system is trying to achieve and how costs sort of shift over time. And again, think about this in a very high-income country setting. Most of what we're providing health services on, it's not to reduce mortality, it's to just keep people from having to pay large hospital bills. And so this really kind of helps countries orient their thinking around the types of services they're purchasing over time. The last thing I'll say is that we think that both of these 2 packages provide good value for money. I'm not going to go into the details here, but we did a separate modeling exercise looking at reductions in under 70 deaths by the year 2030 and compared those to the incremental costs here. And I'll briefly just show you some of the results here. So for low and lower middle income countries, we looked at under 5 deaths and the cost per under 5 death averted. Deaths 5 to 69 from sort of group 1 causes, infectious diseases, and deaths 5 to 69 from NCDs and injuries. And what you see here is that you get numbers that are pretty reasonable looking. For both of the two packages, the smaller and bigger sort of package, you get something like $7 per child death averted, which is pretty reasonable. For in a lower middle income country setting, prices are higher and other sorts of things, and so you have a bit, but these are still really, really nice numbers. And even for NCDs, you have something like $18,000 per adult death averted from highest priority interventions. That's sort of what you might consider a little bit on the borderline for a lot of countries, but it's not ridiculously cost ineffective. But as you begin to get into these sort of really ambitious, like especially in lower middle income countries, a lot of NCD burden, a lot of costs, you get into these sort of very different sort of cost effectiveness ratios. So we think this helps people orient their thinking around like not the cost effectiveness of intervention, but the overall value for money of a package of services around a particular type of set of outcomes. So we do have some limitations. This is just a package of services. It's not everything the health system does. So this is sort of not minimum spend on UHC, but minimum spending on a package of services. Countries will vary in terms of how much they can cover by public finance, but we assume 100%. So coverage targets will vary, public finance will vary. These are cross-sectional cost estimates for sort of a counterfactual. So we're working on expanding that, but this is sort of to be taken with that grain of salt. And of course, there's the usual data limitations around nobody has cost data for most interventions and that sort of thing. So we view these as stylized costs that are meant to start conversations and really help with the priority setting and orienting process in the big picture. So I'll acknowledge my collaborators and a little plug for DCP for those who don't know about it. Thanks.
Questions for David on the DCP3 estimates? Go ahead.
Many hospitals gap between the interventions and the services actually done. So if a patient comes with a problem that the hospital feels it has the capacity to do, but isn't one of the interventions, wouldn't it typically perform that service? And therefore, doesn't your costing sort of need to take into account the imperfect match between the services to be delivered and your very sort of perfected set of packages and interventions and conditions?
Yeah, surgery is probably the most interesting and challenging example for economics because surgery is one of these very strange, peculiar beasts. In contrast to antiretroviral drug treatment, you have these huge economies of scope with surgery, but also these issues around what exactly is a surgeon doing at any point in time with her or his time. And so it's a really challenging area to cost. We tried to identify procedures, a series of 40-something procedures, and the sort of epidemiologic need for those procedures in a given country setting and say, well, if you're just doing these procedures and nothing else, this is how much it would cost to do those procedures. But it's granted that in a given situation, you're paying essentially a fixed cost for a surgeon and for the operating suite, and so they could be doing other things, or they could be not doing these things. So it's frankly one of the more challenging areas to cost, but it's a good point. So we try to get the order of magnitude of those costs, but in any given setting, it's going to fluctuate wildly by day and by time of day.
Okay, one more question? Go ahead.
Thank you very much. I would like to understand better on your cost distribution on the graph that is showing about 40% for the health center level and lower the hospital. Was that based on hypothetical, I think next, yes, that one. Is it based on hypothetical one tool or based on the best practice of existing distribution among these countries?
So this is showing, if you take the overall incremental cost, the additional investments required to reach 80% coverage of all interventions, this is the share of that overall incremental cost according to delivery platform and according to the types of sort of the timing of interventions. And so if that incremental cost is, $250 billion or whatever, this is how it's split up across different types of interventions. And so this is really reflecting the the additional costs needed to get to a certain point based on the sort of best practices for delivering each intervention. And importantly, we worked with our authors and editors in DCP to identify delivery platforms that were ideal scenario delivery platforms. So obviously for NCDs, most care is being done at tertiary hospitals now, but in the real world setting, we'd be doing hypertension care at health centers. And so we're using that sort of standard rather than saying this is what's being done now.
Great. Right. Thank you very much, David. Clap. So,
Yeah, sure.
okay. Oh, wait, so, okay. Great. So I'm Marcia Weaver. I'm presenting on funding and services needed to achieve universal health coverage. The scope of our estimates are the additional outpatient visits and inpatient admissions needed to meet a standard, a utilization standard for universal health coverage for 195 countries. Our modeling approach is to identify a standard of utilization per outpatient visit, a standard of outpatient visits per counterfactual disability-adjusted life year, DALY, to calculate the gap between the standard and the number of visits per counterfactual DALY in a country, and then to multiply that gap by the unit cost of an outpatient visit in the country. And then we do that same calculation over again for inpatient admissions. Our calculations depend on a metric of counterfactual DALYs. The DALYs that are reported each year at a regular frequency by the Global Burden of Disease are endogenous to the health system because better access and quality of care will reduce the burden of disease. So we need to standardize DALYs across countries by removing the effects of access and quality of care. To do that, we regress DALYs per capita from the GBD 2016 study so we regress that on the Social Demographic Index, the SDI, which is a combination of GDP per capita, educational attainment by the age of 15, and fertility under the age of 25. And we also regress it on the Healthcare Access and Quality Index. We do those regressions for both sexes individually and by age group. And then we use the coefficients from those regressions and the error term, which reflects a country-specific effect, and predict the counterfactual DALYs with the HAQ set to 0. So we're basically zeroing out the health system. So here's, oops, did I make this go away? Okay. So these are some examples of our regression results. And as you can see, we have them for both males and females. And if you look at the coefficients of the Healthcare Access and Quality Index, we see that as healthcare and access and quality improve, the DALYs per capita decrease. And the same with SDI. And you can also see that the coefficients are negative, the coefficients are statistically significant for all of these, and that they are larger for early childhood than for older children and adolescents, but then the coefficients start to increase again in middle age, where the health system has an effect, a larger effect on DALYs per capita. So then what we do, so these are some of the summary results of our regressions. The top left, you'll see the global average result, counterfactual DALYs per outpatient visit by age category. Top right are the averages for the high-income countries. Below that is sub-Saharan Africa. So to look at our gap for something like 1 to 4 years, you'd look in high-income countries, if we were using that as our standard, there are about 7 outpatient visits per counterfactual DALY. In sub-Saharan Africa, there are about 2. So we have a gap of 5 outpatient visits per counterfactual DALY, and we would multiply that first by counterfactual DALYs to get a measure in units of visits, and then multiply that by the outpatient visit unit cost. So we did a calculation where we used each country, we did 195 calculations, where we used each country as the standard for utilization. And then we estimated the gap of every other country relative to that standard and calculated the cost of that. And these results here show the calculation using each country as a standard. So you'll see across the horizontal axis is the total cost of universal health coverage in 2017 international dollars, and that axis is on a log scale. And then on the vertical axis is the GDP 2016 UHC index. So higher on the vertical scale is good, lower on the horizontal scale is good. And we actually, you can see here, we have a frontier kind of running across the top of countries that have been able to achieve higher levels of UHC at relatively low costs with their combination of inpatient visits and outpatient visits and inpatient admissions. And you can see Thailand, Maldives, Lebanon, Portugal, Netherlands, Sweden, all create this frontier of efficient health systems for producing UHC. For our estimates, we use the Netherlands as a standard, but a country could choose one of these frontier combinations of outpatient visits and admissions for their standard. And so a country like Swaziland might want to set Thailand as their standard for what they could accomplish in 10 or 11 years. And then for the next plan, they might want to set a higher standard to achieve more UHC. Sweden scored about 0.8 on a 0 to 1 scale for UHC, and that's why we used it for our standard. The source of our estimates, if you had come to my talk at iHEA in Boston, we use national health accounts, which are mutually exclusive, collectively exhaustive accounts of healthcare spending by type of care and by location, and estimated the share of total health expenditure on outpatient visits for all 95 countries. Then we multiply total health expenditure times the share, and then divide that by outpatient visits per capita, and do the same for inpatient admissions. In terms of progression, I think it's interesting to note that when we look at the countries along the frontier, if you look at their visits per counterfactual DALY, they all kind of are in the neighborhood of about 7 outpatient visits per counterfactual DALY, whereas there are real differences in admissions per counterfactual DALY. And it's suggesting that, that it makes sense, as both Karin and David had said, to focus on improving access and quality of care for outpatient visits initially, and then to reach higher and higher levels of UHC that would involve additional investments in inpatient admissions. So what's unique about our contribution are estimates of counterfactual DALYs that enable a comparison of health systems with different combinations of visits and admissions. And then our frontier analysis explored different combinations of services at the health system level rather than at the intervention level. The limitation is that for some countries, the current unit cost may understate the cost of improving the quality of care. So we include 195 countries. For the United States, I think the quality of care that we have is fairly high, so our unit cost estimate will be accurate for the United States, and we estimate the difference, the gap in access to care. Whereas for other countries, the quality of care may also need to improve as well as access to care, and we don't capture that improvement in quality in our unit cost estimates. And then we don't include cost estimates for population-based or community-based platforms. We have all of these estimates that I presented are available on the Global Health Data Exchange, and the GBD estimates are also available on the Data Exchange and in a data viz. And I'll conclude with acknowledgements. Thank you very much. So, questions for me?
Where you mentioned you left out the community part, often patients in low-income countries will go directly to a pharmacy, as you know, and buy products without a professional consultation. And increasing the role of community health workers is promoted as a way of addressing. So how much is that limitation in your system, and are there plans of addressing services that may be delivered through settings other than a formal outpatient setting?
So my colleagues at IHME are conducting a study of the cost estimates for primary health care, and that will include some of the community care and community settings as well. Yeah.
Thanks, Marcia. It's really interesting what you're doing. I just had a question about the graph you showed with the Universal Health Coverage Index versus the cost to reach UHC in 2017. And I was perhaps it's very early on the last morning of iHEA, so perhaps you could just explain a little bit more to me why you wouldn't want all countries to be at a very high Universal Health Coverage Index value. So one of the points that you've got is Chad still sitting at 0.38 or something. I would imagine that what we're actually trying to do is move Chad up to a UHC coverage index of, 0.8, 0.9, 1.0. So is the cost of $72 billion going to get them to 0.38, or is it going to get them up to full UHC coverage?
So the countries that we think are interesting are the ones that form the frontier in the upper left corner. So for Chad, if we use the standard of Chad for the entire world, this would be the estimate of the cost to reach that. But we wouldn't recommend that we use Chad as the standard for the rest of the world. We'd recommend something like Thailand or Maldives or Lebanon.
So then your green text, it says total cost to reach universal health coverage. What does that mean for, how do I interpret this graph as what is the cost for Chad, the total cost to reach universal health coverage from
So
this
this
graph?
is not the cost for Chad. This is the cost using the inpatient and outpatient results per counterfactual DALY. This is the results if Chad was the standard for the rest of the world.
Okay.
Yeah. Okay, so I think I'm going to move on to the discussants. So could we have our first discussant come up? I think it's in the order of the program. Yeah, Neil, thank you.
Yeah, thank you. Good morning. Hi, my name is Neil, and I'm going to present the primary health care cost estimates at country level. Indonesian experience, I see some of the Indonesian colleagues also here. Right. This the context of this study is that after this universal health care estimates by the Karin and all, the WHO wanted to do an independent costing in country level in 4 countries out of these 67. Without referring to this, it's an independent costing using the same methodology to see how it, how it is going to be compatible. So what I'm trying to do is to discuss in very short what we have done in terms of methodology and challenges we faced. So basically, we are only focusing at the moment is only on the primary healthcare part of it, but that when it comes to this SDG price tag, I think it mostly covers the second one. So the cost it is coming out of the study is a portion of the one which is shown by the Karin. Now, a little bit about Indonesia. Now, as you know, it's a very Indonesia is a very large collection of islands and a very big population, relatively very large. They say the fourth largest population, 270 million. And then Indonesia, the primary healthcare is very, in fact, it's legally, defined, like, because there is a decree by the Ministry of Health where they identify 155 clinical conditions delivered through primary healthcare centers, peculiar centers called Puskesmas. They are around 10,000 units like that. Some of them are having inpatient facilities as well. Like, I think about 4,000 out of this 10,000 is having inpatient facilities. And it was run by around 400,000 staff in 10 categories. So what's the difference in the country estimation and this national, the global one is that now we were using kind of a real-time data, what is exactly types and numbers of staff, whereas the other one is for example, from my memories, now human resources were categorized in 4 generic categories, and even the system. And also when we cost we have now, in addition to WHO default, we have customized certain interventions to reflect these guidelines. So that's going to be a difference. And then we have, now this study was done by a team of WHO and also a team from the National Research Institute of Indonesia institution called Litbang case. So a lot of people were involved in that. And then we have focused on initially the scope, intervention cost, in terms of drugs and supplies and the program cost, infrastructure cost, human resource cost, and logistic cost in relation to the existing plan in the country, not with any hypothetical target. So as the Karin explained, now this is usual One Health methodology we have used, the same one, where we use the drugs and supplies by identifying the number of clients based on population and average material cost. Infrastructure is simply the quantity into unit cost, which were the local cost. And the logistics, we found a lot of data constraints in identifying real logistics systems, so we used the 20% of the material cost as the logistic cost and the program cost, also based on the plans. So the major challenges we found was to find out for certain diseases, to find out the descriptive local intervention protocols. So therefore we have used the default in certain cases. And the unit cost also, the problem in Indonesia we found was it was highly varying from one end of the country to the other end. Difference may be 3-4 times. So it was very difficult to go for the country level costing. So we went for a kind of a median. And then coverage targets were also, most of them were based on the expert assumptions. And the system information was sometimes difficult to get. And even the most problem was the identifying the human resource targets and then the infrastructure targets. So then we discussed, and based on certain plans, we managed to go for certain things. So we used the One Health tool, which was discussed by Karin. And a few slides on the results. So we found at the beginning of 2019, overall cost was around 5.2 billion in the primary healthcare. And it was forecasted to be 10.8, almost double, depending on the coverage. And that other system targets, 10.8 billion. And out of them, we found that most of these costs are incurred on more like drugs and supplies, followed by human resource, and then the infrastructure, and the logistic of course the 20%. And then, also the costs are mostly recurrent in nature, relatively low infrastructure investment, capital investment in the primary healthcare system in Indonesia. At least it is not planned. And then when we found, then we tried to get the per capita cost. We found at the beginning for the interventions we selected, it was around $6, whereas in 2030 it was around 19 per capita. This is incremental cost. And then out of this larger drug and supply cost, the most, most of these costs are invested on cardiovascular and diabetes. So it's they are having an NCD kind of epidemic there. And then we try to find out the gap, financial gap in 2030 by considering the current level of per capita expenses based on national health account, which was around 27, which is larger than what, bit larger than what we have found in the study. And then we knew that we need to increase the $19 per capita within the course. So in 2030, this 27 would have to be increased by 70% to become 46. So that's the gap to be filled. And then, and finally, that following this primary healthcare cost, now the Indonesian government is now, trying to expand this study to cover the full set of universal healthcare coverage. And also, in that also, I'm involved in that, the approach with the One Health tool. And also they say that once we finalize this study, they are going, the Bafanas, I think it's the Treasury in Indonesia, is planning to use this tool to coming years to, for their future plans. Thank you. Yes. Yes, sir. Please, yeah.
Thank you very much. I'm Hasbullah from Indonesia, so I would like to comment on this.
Yes, sir.
First, I think what you are calculating is based on the public health center only, so not the private.
It's completely on the whole Puskesmas.
Yeah, that's right. That's a public one.
Yeah.
The
yes.
primary health care is not only provided in the public sector.
Yeah.
Maybe more in the private sector than in public sector. The second one, the cost that you illustrate was, in my view, it is biased or endogenous because that set by the low fees from our national health insurance, because the payment for capitation is determined unilaterally. So, third, if you said there are variation across province, that's because for the public health, the establishment or the development of public health centers is not based on the population needs. It's influenced a lot by local politics, and therefore variation becomes very high. It will be very different if you calculate for private health, primary care, where the investment or the hiring of human resources will be based on the market demand. It will be very different. It's good to compare to. Thank you.
Okay, let me give a quick response. The first one is that the problem of this private-public issue was discussed in the team, but then we found that hardly any data can be found to calculate the private cost. Therefore, the final decision was arrived to cost as if whole country is treated by the government. So that's the kind of a basic assumption made. The second one, now I don't, it's a long question. The second one, yeah, variation across, of course, it is there that we couldn't help. We have to, and your second question, I had answer, but.
Because public health center receiving capitation payment from the BPJS, the national insurance, the payment is set by the Ministry of Health.
Now,
Yeah.
to answer that, now we did not base any of this costing based on insurance claims. It was based on actuals, like identifying the drugs and drug cost and salaries and number of people. So the cost is independent of what is paid by the JKN. But now finally they say that there seems to be a big imbalance between that amount paid and the actual cost. Now, because now we are now expanding it into the full RPGMN plan cost, where we find that now one of the experts say that what you pay as an amount per patient from the insurance system is not compatible with the per capita cost because it is not based on that. So it's kind of arbitrary divisions. So but it's, these things are quite complex. I think it's not the forum to discuss. Thank you very much, sir, for...
Yeah. Thank you, Neil. I think we're going to move on, but thank you very much. So, Alemayehu, you're next.
Morning. Thank you, the presenters before me. It was a very impressive presentation, and I will give some additional inputs about the costing of for universal health care from country perspective, and I will talk about Ethiopia. Just before I go to the main costing issues in Ethiopia, I will give you a few, 2 or 3 points about what the healthcare financing in Ethiopia looks like. This is the per capita expenditure on health across different years from 1995 to 2013. That's the recent information. As you see, there is increment, but still it is around less than $30 US per capita from the recent. So the other price tags estimates can be compared with what's happening in the country and how much is needed in addition to what is going on in the country. And the other issue I want to add is about UHC. Where are we now in terms of universal coverage in Ethiopia? And there is a good estimate based on country-level data on UHC, and you can see there is very low universal health coverage in Ethiopia if you take it. And there is also very huge variation across different regions. And like, if you take Ethiopia, it is a country with more than 100 million population, and each of the regions are comparable with some kinds of countries. And we have also huge difference in terms of universal health coverage across different program areas, and different program areas also needs different per capita investment or to deliver different types of service. This is additional complexity in understanding UHC and UHC costing, how much resource we need, and so on. Just I want to add these points to the discussion, today's discussion. So we are doing country-level estimate for universal health coverage, including more than 1,000 interventions for the Ethiopian Essential Health Service Package. We are using One Health tool, and cost estimates are based on best data at the country level, and we use official figures for base year population, demographic. We use the same costing approach with what you did in Indonesia, and the country level estimate Karin was doing, and I think Karin is also part of this work. So that result is not yet ready. It will be ready in a couple of weeks. And I want to show you the result from the previous work, which is very, very similar with what we are expecting for the 1,000 interventions in Ethiopia. So we have the total resource need from 2015 to 2020, and large of the cost is for human resource and for medicine and supplies. So when we project that to 2030, there is a huge gap between the resource need and the resource available. And yeah, this is just crude estimate, and it's not a citable figure yet, but there is a widening gap in the current trade. And so the main message here is, I mean, we need to know at a country level, based on actual resource, based on actual disease burden, based on actual targets, and based on the real mix of service we want to deliver. We need to compute that number and find resource from domestic or whatever, and try to narrow the gap. That is very important, but we need also the numbers, and I don't want to give very conclusive issues now, but what do global level estimates imply? That's I think the key point we can talk in detail. And what should countries do? I mean, we have this number, we have also numbers from countries. Thank you so much.
Do it.
That on?
Yeah. No question. Perfect.
Okay, so Sayem, would you like to go next? Thank you. Thank you.
Yeah, good morning, everyone. My name is Sayem Ahmed, working with Health Economics and Financing Research Group, ICDDRB. I will talk about our study in Bangladesh on essential service package costing from 2017 to 2022. And this study was requested by Health Economics Unit of Ministry of Health. And we conducted this study through technical support and funding support from WHO Bangladesh office. And in this study, we estimated cost of 132 intervention under the essential service package using One Health tool. And the essential service package, it is not very new in Bangladesh. It was initially started in 1998, but it is recently updated according to current burden of disease, because all we know the burden of NCD is increasing in country like Bangladesh, also in low and middle income countries. So and government including this in the current sector-wide program, five-year plan, to provide access to the poor people to the universal access to these services, And the government of Bangladesh has little capacity to invest in health, and the public spending is still poor in Bangladesh, because of the total health expenditure, 67% is still coming from the out-of-pocket payment, and government spent only 23%. And the current per capita health spending is $37 per capita. And the private sector is growing very fast currently, and public sector is currently very steady. And so government has some interest to improve the investment, but they have very poor tax base to invest more. So in this study, we covered this essential service package, which includes 5 core services, including the maternal and child health. That includes the maternal and newborn care, immunization, and other services. And also we have family planning, nutrition, communicable diseases, non-communicable diseases, and management of other common conditions. And government develop a intervention list and also a good document on the essential service package to include in the health sector program. Yeah. And this is the mainstream service provider from the government part. That is in rural areas, we have Upazila Health Complex that provides some inpatient care and outpatient care, and all other facilities like union sub-centers, union health and family welfare centers. These mostly provide the outpatient center. And district hospital, it is located in urban areas, but it works as a referral facility for these hospitals. And in urban area, it covered by district hospital, maternal and child welfare center, and urban these facilities mostly. And there are differences in Bangladesh, like rural area, it is mostly oversight by Ministry of Health. And in urban areas, most of the health facilities are oversight by Ministry of Local Government Department. So at first we customized the One Health tool that is provided by World Health Organization according to the essential service package intervention in Bangladesh. And we customize the health system module and also health service module according to the ESP document of the government. And for the cost calculation, this is the built-in model in the One Health tool. That is, we need to estimate the population in need based on the prevalence and target population for each intervention. Then we estimated the population receiving intervention or beneficiaries. That is population in need and percentage coverage by the public facilities only, because there are private sector and NGO sector that also providing ESP services, but that is not a scope of this study. So finally, the intervention cost that will be calculated by population receiving the intervention and unit cost per services. So these are the data sources, and we have a lot of consultative meetings with the government, and Health Economics Unit of the Ministry of Health was very supportive to this study. And also we reviewed some document, program implementation plan of the government and operation plans to extract all this information. And the target year information in this study was not based on the need of the population. It is mostly based on the target government have to achieve, like percentage coverage they want to achieve. Because the government has limitation to on their budget. So through consultation with government, we use that as a target in this study. And this is the result from this analysis. And as we see in 2016, around 76 billion Bangladeshi taka was spent on ESP, and it will increase around 103 billion in 2022. And as a per capita, it is $6.1 per capita, and it will be $7.4 per capita. And by the cost component, human resource and medicine supplies was the main contributor in this total cost. And this is by the program. If we can see, that is NCD, spending for NCD will increase here threefold, around threefold. And MNCS is quite steady in this period. And I already explained this, and so I'm going to next slide. So the unique contribution of this study is this is the first time government has cost information of this high number of intervention, and government used it in various purposes, like to estimate the spending for the Rohingya crisis also. Director General of Health Economics Unit requested unit cost from us, from this study. And also they have planned to use this cost estimate to implement the Shastro Suruksha Karmasuchi. That is the health insurance scheme government want to start for the poor people from the subsidy from the government. And we have some limitation, as I mentioned already, that is we were not able to include the NGO and private sector contribution in this costing. And also we excluded some government facilities that is not in the ESP document. And finally, we were not able to project the human resource requirement. We use the current available human resource in this study. So that's all from.
Great, thank you. Okay, questions for Sayem? Right, if there are no questions, I think I'd like to open this up for a more general discussion. So for others in the audience who are conducting cost estimates for UHC programs, maybe you could share with us what methods you're using for those cost estimates, what you found helpful and what you're finding challenging. So who else is doing some universal healthcare cost estimates? Go ahead.
Can I just first ask a clarifying question, and then? I'd like to ask about the labor cost in both models.
Okay.
In the One Health tool and DCP3.
Mm-hmm.
So what I understand is, for the One Health tool, you estimate the gap between the existing and the normative targets, right? But for the DCP3, it's based on the population needs. So for example, if we have a prevalence and incidence of diabetes and hypertension, then we estimate that the doctor would spend 10 minutes to see a patient for diabetes, and then 10 minutes for hypertension. Then I upgrade with the prevalence and incidence data, right?
Well, for the cost, it has the labor cost.
Oh, yeah. Sorry. Okay.
So that's not quite correct. The unit costs that we have from the literature have labor cost included in them. And so that's where we get the numbers from. So it's the population need is sort of separate from that. But, for instance, if the cost of ARVs is, $200 per person per year, whatever, then the labor costs are part of that number, so as well as the commodities and other things.
Let me just clarify. So I mean the human resources cost, the human resources cost for the model. So I need also to estimate the resources for the number of doctors needed to deliver this package of service, right? And then I multiply by the salaries, and then I will say that this package will cost me that much.
We didn't directly do that, but it's possible to do that. We didn't, for this analysis, we didn't kind of break down by those particular pieces of, but it's something that we could certainly do. Yeah, but I don't present those here.
So for the DCP, do you have a breakdown for the cost? Like this medicines would cost that much, and the human resources would be.
Right. No. So what we just took the unit cost sort of at face value, and so what we are working on doing is we're kind of building out the model now, and working in countries is kind of giving that information to countries, so we extract that from the unit cost numbers. So yeah.
Good.
Something that
Yeah.
So for the work that we did at WHO, we used two approaches, bottom-up and top-down. So the top-down is based on a normative kind of benchmark for the health worker ratio that you need per 1,000 population. And we divided it by different cadres of health workforce. So we did that top-down estimate, but we also did a bottom-up estimate where we took for each intervention, each person reached the number of minutes needed by a specific health workforce cadre and multiplied it up to get the number of personnel needed. So we did both the bottom-up and the top-down as a validation. And then we multiplied for each country, each cadre by the cadre-specific salary estimate.
So are there other questions, comments, experiences with UHC cost estimates?
I'm Don Shepard Brandeis. With colleagues in Jordan, we were trying to look at the cost of expanding services for there. Jordan has a really interesting system, which they call the Civil Insurance Program, that covers government workers and some other formal sector workers. And so the process that we then did was to try to build on that experience. It said, for the people who are covered, what is the volume of services? The same framework we saw, the outpatient visits and inpatient bed days per person covered, and the unit cost of each of those two types of services. And we then, from household surveys, there were data on the use of people who are not covered, which was less, as one would expect. And so then, essentially, the model looked at the increase in use of services per person if they gain coverage for ambulatory services and outpatient, multiplied those by the respective unit costs. And that was it was a process that had the advantage of being based in actual data from the country, and the data to do that were available.
Nice, nice. Thank you. Go ahead. Here. You're fast.
My name is Munge. I work with the Health Benefits Package Advisory Panel in Kenya. And I think the lesson for us when performing the costing was the experience from the countries, that it's really important to have country-specific evidence, and particularly for some of those sectors that are often not considered, the not-for-profit sector and the for-profit sector, understanding some of their costing structures and the things that contribute to that can lead to significantly different understandings of that. I think the second aspect is, as they discussed, again, understanding local context in terms of within-country heterogeneity, in terms of service coverage and readiness to offer those services. So I think that's also an important consideration that is difficult to tease out from global estimates. And the, oh goodness, I've forgotten what the third point was. Yeah, but I think those two should suffice. Thanks.
Good. Okay, I think we have time for one more comment. Great.
Hello, my name's Kim Sweeney, Victoria University in Melbourne, Australia. We've recently been doing a number of investment cases for adolescents. If you look at the burden of disease for adolescents, particularly 15 to 19 and 20 to 24-year-olds, road traffic injuries, or injuries generally, and road traffic injuries in particular, are very important. And they seem to have been neglected within the sort of modelling frameworks that people use. We were forced to build our own model about road traffic injuries. So I just wonder if you'd like to comment on that at all. And the other aspect was self-harm and suicide, which also sort of are neglected within the modelling framework.
Karin, David, did either of you include road traffic injuries or?
Thanks. We did not, for the lack of having a model available, and we acknowledge that as one of the missing areas that need to be dealt with because of the need to have cross-sectoral investments to attain the targets.
We included, we defined UHC within the health sector, so there are sort of separate pieces around road safety. So we costed the aspects around surgical care for injuries. So a lot of those first level hospital costs that I showed you in that bar graph for urgent interventions were around surgery for trauma. So those costs are included in DCP's essential surgery package, and there's a package on musculoskeletal disorders as well. So those are there, but the road safety costs are not borne by the health sector, so we didn't include those costs. Yeah.
Well, I think the national health account,
We don't have really good costing information on that sort of thing either, so I think it's a real important area for cross-ministerial collaboration.
Okay, so thank you very much to the presenters, to the discussants, and to you for coming out this morning.